Okay, so now on to what diathermy does in the body. So now that we know that it produces these electromagnetic waves, the eddy currents and the dipole movement cause friction. That's going to cause our heating and our non-thermal effects as well. So again, similar to ultrasound, we get both non-thermal and thermal effects. So whenever the pulse shortwave diathermy is applied, the non-thermal effects are occurring. If we keep the energy high enough, we'll get both. And so for non-thermal effects only, we have to keep that average power kind of below 38 watts. Anything above that, and we'll start to get some heating. Um, so it just also depends on our settings for that as well. So high frequency electromagnetic energy, again, greater than about 10 megahertz is absorbed in the patient's tissues. The specific absorption rate describes the rate of energy absorption per unit area. The friction that's caused by the movement of ions is what gets us our heating effect. So free ions within the treatment field end up being attracted to either pole. And then we create that friction that's happening as those molecules move around. So also then going to create, again, those eddy currents, those kind of side currents of rotation that are going to cause that friction. So non-thermal effects are typically obtained when we have low output power or low duty cycle, or usually both. Non-thermal effects usually have low number of pulses, short pulse duration, and keep that average intensity low, below 38 watts. We'll see kind of in our next slides like what all that non-thermal really does, but it's the non-thermal would be our typical, just like with ultrasound, right? Our indications would be acute trauma, post-surgical treatment, and then, our thermal would be all of our indications that we had for even our superficial heat for thermal that go back a couple weeks now. So, we can really target kind of those different areas as well. So here's our typical schematic of our effects from the electromagnetic waves. So the electromagnetic waves are produced either through a capacitive method or inductive method, and we end up in the same results. So even though we have different ways to get there, it kind of depends on the machine that you're exposed to. We tend to get to the same results, even though they target different tissue. So the induction mainly targeting the muscle, bone, blood vessels, nerve. The tissue in the capacitive is mainly being the adipose tissue or skin, and then we get to the muscle via conduction. So even though those pathways that we talked about are different, we still get the same results. So we can either get non-thermal, which is usually our short pulse duration, short frequency. We can also get then our thermal, which is usually our long pulse duration, high intensities. This says 100% duty cycle. Again, we don't use continuous very often. We're still using pulses, and the machine usually presets that. But we have much more likely to get all the different heating levels that we have, but we definitely can get that vigorous heating, especially because we can get so much volume and we get a higher temperature with that volume, and we also get that longer retention of the heat and that longer stretch window. In our non-thermals, we have kind of three major categories that our effects are going to fall under. We get this increased vascular perfusion, so our capillary regrowth. We see a lot more of that blood flow for regrowth, as well as then just opening up those blood vessels. Blood pressure kind of on the microscopic level actually increases, so we get effects there. Activation of fibroblast growth factors, so kind of tissue healing, and increased macrophage activity, so increased tissue, cleanup of debris. So all that kind of ends up resulting in improved tissue healing. So let's talk about those non-thermal effects first. So the way we get our non-thermal effects is due to the changes in the way the ions are binding to the cell membranes because of those currents passing through, okay? And that's going to end up changing the cell function. So that's caused by the EM waves and the currents, those eddy currents being produced, the dipole effects. So again, low number of pulses, short pulse duration, low average power output is going to get us just these results. Okay, so things like repolarization of damaged cells, we know that that is a problem when we have an injury, that the cells don't depolarize in the same manner, and so we get that repolarization of that. So it kind of helps sick cells essentially get better and return to normal function. The acceleration of cell growth and division, that's especially when it's already happening too slowly because of injury. And then the next step there, right, we get inhibition of cell growth when it's happening too rapidly because of changes in the dynamics. So it can actually help on either spectrum depending to kind of get us back to more of what would be considered normal. Reestablishment of the sodium pump, increased microvascular perfusion, so that gives us more oxygen, more nutrient availability. Improved cell function, so injured cells have that reduced cell membrane potential, and that has been disrupting the cell function with an injured cell, and so that improves. We get an increased number of white blood cells, so the macrophages in the area, so that's going to improve tissue cleanup. And it definitely helps promote edema reduction by opening up those microscopic blood vessel perfusion. By opening that up, there's more channels for the debris to leave, as well as we get more macrophages helping to clean up that edema. So there's a lot of potential there for helping with edema reduction. So then our thermal effects, we can cause significant temperature increases 4 to 5 centimeters deep in a really large volume area. Again, think that cereal bowl. Anytime we're kind of greater than our 38 watts. So these then become all of our same thermal effects, right? So when the tissue temp increases, we get all this whole list here of effects to the body. So depending on the level of heating that we get increased blood flow, vasodilation, relaxation of the tissue, decreased muscle spasms and muscle relaxation, decreased joint stiffness, increased membrane filtration and diffusion. So again, that helps, especially we see a lot of benefits with old hematoma reduction, deep in the muscle tissue. Increased tissue metabolic rate, changes in the enzyme reactions, decreased viscosity, and again we have that large stretch window that we can be working with. Decreased synovitis and arthritis, so it kind of loosens up the synovial fluid, which helps with a lot of the symptoms in arthritis. Realignment of collagen fibers, again that increased hematoma absorption, muscle reaction, pain reduction, for all the same reasons that we got that with our superficial heating and with our ultrasound heating. It's just this is a different way to get those tissues. So if we're using the inductive method, this is how we get to our heating, which is by far the most common against shortwave diathermy that we're getting. We're targeting those good electrical conductors, so muscle, blood vessels, nerve. We don't really affect the adipose tissue with our heating, but we do know the layer, how thick that layer of adipose tissue will decrease the strength of the wave as it enters the tissue. So we do need to take that into account when we think treatment time and our power settings. Peak temperatures are reached usually in an area that's about the size of the face of the drum. So unlike the ultrasound where we had to know about the ERA and that was smaller than the face of the sound head, in this case the area is usually equal to the size of the face, plus we get that volume with the depth. Peak temperatures are reached usually about 15 minutes into the treatment. It can increase the muscular temperature at a depth of 1.2 centimeters by more than 18 degrees Fahrenheit or 10 degrees Celsius. So this was our typical kind of treatment ultrasound depth, and we were not getting that deep. Can increase subcutaneous tissue temperatures to 5 degrees with even a 10-minute treatment. So again, the length of the treatment will affect the amount of heat that we're getting. So we would think about that as well. With our capacitive method, this is going to heat tissues that are not good electrical conductors, skin and adipose tissue especially. So in this case, we're actually going to raise skin temperature much more so than in our inductive method. So we get that skin temperature increase approximately 4.3 degrees Fahrenheit, and interarticular temperature increases of about 2.5 degrees Fahrenheit. Um, this is again usually at depths somewhere between 2 to 5 centimeters. And then we use the secondary heating of the superficial muscle layer, which is usually our target. We get that through the conduction. It's conducted from above from the adipose tissue and the skin. So intermuscular temperatures can get up to 7 degrees Fahrenheit or 3.9 degrees Celsius inside the muscle temperatures. So those are similar intermuscular temperatures to ultrasound. So here's just kind of a drawing of that. So with the drum, okay, we produce those electromagnetic waves in the drum and they're sent into the tissue. They kind of ignore the fat and then they really target the muscle and they've diminished by the time they get to the bone. Now this is showing that this would be like, so think about like your quad. If we went in through the anterior side of your quad and, you know, looking towards the posterior side. So we have fat and skin, we have your quads, we have your femur bone, we would have your hamstrings, and then we'd have the fat and skin on the other side. So we end up really targeting just the side that the drum is facing. With the capacitive plates, you would have one on the quad side and one on the hamstring side of the leg. And we end up having and losing a lot of our heat to the fat and the skin on the closest side to the plates on both sides, and then we don't have a lot of energy for the muscle. We get a little bump up with the bone, but then again, not a lot here for the muscle. And so we rely on the fact that as the adipose tissue heats up on both sides, the conduction will end up sending some of that heat into the muscle area. Same with the non-thermal effects, but usually a little less. So the capacitive plates aren't as great of getting those non-thermal effects in the muscle. But with the heating, we can get those heating factors to then conduct from the adipose tissue into the muscle. So kind of secondary heating that way. Okay, so like we've done for the other modalities, let's talk about how diathermy affects the injury response process in the very specific ways. So the temperature increases are based on the treatment intensity. So again, usually our high pulse rates and our high pulse widths give us the energy needed to increase the tissue temp. Vigorous heating occurs when the baseline tissue temperature increases at least to 4 degrees Celsius, or between 3 and 4 degrees Celsius. So that intermuscular temperature is in the range of somewhere 38 degrees to 40 degrees Celsius. Increasing the temperature too rapidly or too over that 40 degrees Celsius or 104 degrees Fahrenheit can cause burns and actually, you know, damage. We can break down protein-rich tissues. So we really want to monitor that we don't get too fast of an increase. And so we talk to our patient and talk about the sensations that they're feeling, as well as we want to make sure that we don't leave the treatment time on too long, that we get too much heating. So specifically looking at inflammation, the non-thermal effects of shortwave diathermy is going to alter the rate of diffusion across the cell membranes. The thermal effects are going to increase the rate of cell metabolism, which would dramatically affect inflammation. So at 18 degrees Fahrenheit, increase in the intermuscular temperature will approximately double the rate of cell metabolism. We talked about that with ultrasound as well. We get increased delivery and concentration of white blood cells. So that's going to also then improve chondrocyte proliferation, which is all going to help to clean up the side effects of inflammation and move us from inflammation into the proliferation phase and eventually maturation phases. We're going to get a lot of removal of cellular debris and metabolic toxins, all because of, again, those non-thermal effects, as well as, you know, if we're in the later stages into the proliferation, that increased cell metabolism. So as far as nerve conduction and pain control, we get primary pain relief, meaning that because we reduce what would be causing pain, we would eventually then improve pain. So it's not like our secondary pain relief that we get with e-stim, where we're trying to block the nerve conduction of the pain fibers. Here we're trying to correct whatever is going on so that we don't have that pain stimulation. So primary pain relief due to decreasing the pain on the muscle spasms, so that breaks up our pain spasm cycle. We get reduction of adhesions and contractures, which would be causing mechanical pressure and pain. and we get that increased blood flow, which helps to remove all of the chemical mediators from the area that might be aggravating the pain receptors. And then just in general, all of our same general heat effects. So if you looked back at our ultrasound or our superficial heating, how they affected nerve conduction and pain control, we get increased pain threshold, and all of those things are also occurring with our diathermy. Blood and fluid dynamics, we get vasodilation that increases the blood flow, increases capillary filtration, capillary pressure, and oxygen perfusion. And then deeper in the tissues is targeted than compared to our superficial heating. So we get all that blood and fluid dynamics even deeper into the tissue. And so we target even more capillaries and more blood vessels. So we get an even greater increase in changes in our blood and fluid dynamics. So it's really good at reducing hematomas. On tissue elasticity, again, we can get to vigorous heating. We can get to really good depths, greater than 2 centimeters, greater than our superficial heating, greater than our ultrasound. We get that bigger volume as well. So when we apply the diathermy and then apply external forces, stretching, joint mobs, traction, we can elongate the tissues. And because we have that longer heating retention, that's going to mean a longer stretch window. We do need multiple treatments, just like for any changes in tissue elongation. It's not just a one-time shot. We got to do this over the course of several days, multiple treatments in order to get that elongation. As far as wound healing goes, we can increase certain factors and decrease other factors that would affect wound healing. So we increase white blood cell infiltration, we increase the rate of phagocytosis, we increase the number as well as the quality of the collagen that is being laid down. We can also decrease our healing time, decrease the need for pain meds, and decrease the proportion of essentially dead muscle fibers or necrosed muscle fibers. However, we don't want to use it on open superficial wounds. Moisture is not our friend with diathermy because the moisture will heat faster than the tissue, and so it can cause burns. So wounds that are really moist and wet and open, those aren't good for diathermy.